again. My great pleasure to be here. I'd like to talk about the primary prevention of ASCVD. As you know that the drugs for primary prevention of CVD, statin, aspirin, antihypertensive medications, and cessation of smoking may be questionable, not yet the data, but data for the stopping smoking. As you can see, the primary prevention study is very rare, but the most study come from BP lowering drug test study and statin study. And as you know, that aspirin study is very limited number. And in the aspect of aspirin, the mortality lowering effect very small, about 5%. But as compared with that, the adverse event effect, the bleeding, is high. And the quality of evidence is very concrete, high and moderate. And what about BP lowering study? The risk reduction rate from 20 to 10%, but the adverse effect also high. And the quality of this study is very low. It means that adverse effect study is very quality is low. And what about statin? The benefit is established and the adverse event is very low, similar or very small. And the evidence is very concrete, moderate and high. And tobacco cessation drugs have a very good efficacy, about 2-fold, but also have a side effect and very concrete evidence. Let's look at the statin first. As you know that as well as the secondary prevention, the primary prevention efficacy is proven. So in spite of limited studies, the studies also always show that the benefit from the primary prevention by the drugs and genetic studies. It means that the lower the LDL, the lower the better. The better outcome. The representative study is Jupiter study. It deals with the rosuvastatin 20 milligram per day. And as you know, that the rosuvastatin showed the benefit in the primary prevention in the metabolic syndrome patient with no other disease. So the American guidelines represent four major indication for the primary statin indication, and among that the 3 is the primary prevention candidate: LDL over 190, diabetes in the middle age, and patient with risk over 7.5. This calculator is composed of sex, age, race, total cholesterol, HDL level, BP, whether or not the treating with the antihypertensive medication, diabetes, and smoking. But the problem is that this guideline makes so many patients to be treated with the statin. It means that previously the Framingham score indicate the 1/3 low risk, approximately 1/3 intermediate and high risk. But by this risk scoring system, so many high risk patients. So that's a problem, as you know. As you can see that in the overall diabetics and non-diabetic patient, this red line indicate the risk by this calculation by the American guideline, and this blue line is actual observed patient. So it means that overestimation of the risk patient is irrespective of the diabetes or not. That's a problem. So some argue that this equation should not be applied to all the patients. I think that especially not to the Asian people. But some argue that this American guideline is good. Some American researchers compare the these strategies. This American guideline, it means that age at the middle and 10-year risk over 7.5 and LDL 190. And the very concrete, very orthodox criteria with each primary prevention strategy adoption. And the third is hybrid. In some part from this, each guideline indication plus or this ACCAH guideline. As you can expect, this concrete primary prevention trials indication, by these indications, so many people are included in the statin primary prevention. And the middle is ACCAH guideline, and the hybrid approach, the smallest number of patients included in the statin primary prevention. So anyway, the authors conclude that this ACCAH guideline has have a priority to the other strategy. But in Korea, we also, some researchers compare this strategies problem and they develop new method for that. With these Korean researchers also find that the overestimation by this American guideline, as you can see, the actual black bar instance of CAD as compared with that, the calculated risk is higher than this one. In the white people and also in the American African people. But by this new Korean risk calculation, this was more accurate than the previous ACCAH guidelines. So I think that the another guideline for the fit for the people at another country may be beneficial than solely adopt the American or other countries' guideline, I think. So the author conclude that the ACCAH American guideline should not be directly applied to the Korean population. Let's look at the another viewpoint. Some researchers recommend some statin use by this, like this flow chart. You can focus on this side. If the patient have an intermediate risk or low risk, especially the low risk over 5% or under at the middle age, 40 to 75, can be tested with the coronary artery calcium, and this may be helpful in predicting the risk. And even if the patient have an indication for the used the statin, clinicians and patient discussion should be performed. This is very conservative method. I think that the cause of this is a side effect of statin in the America, if reliable in the initiation statin. So the calcium score and the coronary artery plaque is very easily performed, and not so much money is needed. So some suggest that disease guided statin therapy. It means that irrespective of the risk factors, clinical risk factor of the patient, some findings from the test should be adopted in the total risk stratification. Individuals free of ASCVD, if the patient have indication for statin in this guideline, if the subclinical atherosclerosis test was performed, if yes, some atherosclerosis is detected, then the up classification, and if not, down classification. By this, the eligible patient for the statin should may be reduced. So usually statin use can be avoided, especially in Asian people, I think. It's one suggestion from research researchers. And as you know that the coronary calcium score and have consistently show the risk stratification. It means that 100 over 100 high risk, and 0 lowest risk, and intermediate risk. As you can see, coronary heart disease or cardiovascular disease total. Same trend. And carotid plaque burden over 300 highest risk, 0 lowest risk, intermediate risk. Coronary heart or cardiovascular disease also. As you can see, this longitudinal axis is pooled cortication risk score, and vertical is prevalence of coronary heart disease or CVD. As you can expect, in the low number, the low high calcium score, as you can expect, and the high purification number risk, the high calcium score, as you can expect. But in this, even though patients have a low score, they may have a high number of calcium score, and even the patient have a high risk score, they have very low calcium score. So some mismatching, 10% and 20%. So I think that the calcium scoring system may be helpful, especially in this paradoxical result, patient showing the paradoxical result. Also apply to the carotid plaque burden. So let's look at the calcium and plaque. I think that the calcium and plaque can be positioned in the middle status between the illness, disease, and healthy status. So some say that the presence of calcium is a very useful predictor, as well as the traditional risk factors. In Korea, also we show that the calcium score can be a useful method for predicting. If the patient have a tiny risk over 10 risk over 10%, calcium score over 20 or 100 is increased. This is quartile is premium risk. As the risk increased, linearly increased the calcium score in Korean people. And also, it is in the separate position with the risk score. Even though patient have no risk factor clinically, if the patient have a calcium score over 100, the total risk is up to 10 folds. So the calcium score's usefulness is also can be found. And what about the combining of a calcium score and carotid plaque? It also synergistic predictive power for the calculating and predicting the future CVD. And I personally think that the age is most important. Some argue that the age is not important. In this model, ACVD event, coronary heart, and stroke event can be predicted with the calcium with a minus age. It means that age calcium score may be an independent risk factor regardless of the age status. So a very interesting paper. So some investigators argue and suggest that this very similar flow chart, if the patient have an intermediate risk, 5 to 7.5% 10-year risk, what about the patient B tested C coronary calcium or plaque? And if the calcium score under 100, this profile, very complex but very simple. If the calcium score under 100, if the patient have a plaque, they can be recommended statin and aspirin. Calcium under 100 and presence of plaque, statin, aspirin, as well as the lifestyle medication. If no plaque and the small calcium, then the only therapeutic lifestyle medication can be recommended. Let's look at the aspirin. As you know, the aspirin have a benefit, very limited benefit. Majorly coronary event to the man and ischemic stroke benefit to the woman. And the dose is from 75 to 300. As you know that the higher dose, the higher risk of bleeding. And as you know that the secondary prevention, very well known benefit with the aspirin. But the primary prevention, as you know, that the bleeding risk. As you can see, the risk of bleeding is increased as the age increased, and very complex graph, but can be simple. In this patient with the age over 80s, the history of ulcer is very high risk of bleeding later. And uncompleted also this, and just GI pain, this, and no history, this. And the red color is aspirin, and blue color is control, no aspirin. The aspirin show increase the risk of bleeding as compared with the control. Aspirin, no aspirin, aspirin, no aspirin. And the in the control also, the history of ulcer and pain increase the bleeding. So as you know that the history is very important, ulcer, GI pain, and others, other medication, and age. And the risk of bleeding is this, and the benefit is like this. This axis is annual risk of a vascular event, and this axis is avoided vascular event. So the cutoff is about 1.0%. So I mean that the 1% of annual risk or over, they can be a benefit for the net benefit of risk reduction as a vascular aspect than the bleeding side effect. So some suggested this diagram. If the patient have a risk of 0.7 to 1.4, if the patient have a strong preference for aspirin, or hypertension with target organ damage, or diabetes, or poor physical fitness, if yes, aspirin low dose, and no aspirin. If the high risk of 1.5%, then the aspirin low dose. We also have a data. The data from the National Health Service, National Court study, we investigate the aspirin and statin's efficacy. No drugs, only statin, only aspirin, and both at the same time and at a separate time. As you can see, no treatment has a poorest outcome, and both or statin only have a best outcome, and aspirin intermediate outcome. Whole cause mortality. And cardiovascular mortality also same trend. So all cause and cardiovascular mortality rate like this. No treatment, highest. Combination and statin, 4%. Aspirin alone, 8%. Same trend. So the author conclude that the primary prevention with these drugs is beneficial in both all cause and cardiovascular mortality in uncomplicated hypertensive patient. But the aspirin should be used very cautiously. So I'd like to conclude that aspirin used for primary prevention should be highly individualized. You should be benefit and the harm of aspirin, bleeding and CVD benefit, and balancing should be thought, and patient preference regarding anticipated long-term treatment should be discussed and consider the GI bleeding risk. And my personal opinion is that the risk is increased as the age increased. So the age cannot be corrected. And the residual risk with the statin or other drugs present, I think that because of the age. So can he perfectly 100% prevent AES, CVD, and death? Definitely no. All the people die at some time. But most important residual risk, not modified risk, is aging, as you know, and gene. But prostate with pessimism? No, we have modified factors we can correct yet. So I think that primary prevention of ASCVD is, I think that the most beneficial and most useful drug is statin instead of aspirin. But aspirin has some role. And controversies on statin use present with a poor quality education by the American. But we should adopt other guidelines best fit for the Koreans or Chinese. And aspirin use also should be balanced, always with the risk of GI bleeding. And the testing with the coronary artery calcium or plaque may be considered, and it might be helpful in risk prediction in low, especially low or intermediate risk groups. Thank you for attention.